Welcome to Medica Cardio Talk. Today is our 21st episode of Medica Cardio Talk. With me, my colleague, Dr. Dilip Kumar, Director of Cath Lab of Medica. Today, we are going to discuss about the tricuspid valve replacement, primarily transcatheter tricuspid valve replacement or catheter-based tricuspid valve replacement. But before that, we would like to talk and discuss with my colleague Dr. Dilip Kumar about why tricuspid valve is so important. What exactly is tricuspid valve? Dr. Dilip Kumar.
Yeah, thank you, sir. And we are really moving towards a very exciting phase of structural heart interventions. And the tricuspid valve is a very special, it has got a very special place. Everyone who has a more than moderate TR is going to have a very bad prognosis, and the survival rate of a primary TR, significant primary TR after 5 years, is something around 48%.
This TR or tricuspid regurgitation that you are talking about, is it a functional tricuspid regurgitation or structural tricuspid regurgitation or both?
Yeah, so it's also very fascinating here. Majority of the times the tricuspid valve problems is not its own problem. It's all functional pertaining to a left-sided problem. So
right.
One has a MR or a left-sided pathology, LV dysfunction, and functionally the tricuspid valve is affected because of annular dilatation and RV dilatation. So around 60-65% it is functional or secondary, and 30-35% or even less is the primary TR pathology.
Right. So, but whatever it may be, if you get tricuspid regurgitation and if there is a progressive right ventricular dysfunction, clearly the prognosis is poor and the survival rate progressively comes down. So, what we, the intervention cardiologists, are doing to address this severe problem?
Yeah, I think before that, I think one message has to be very clearly go to everyone that if the surgeons dealing with left-sided pathology and any significant TR, if it is associated with symptomatic or maybe a RV dysfunction or annular dilatation, they should go for a tricuspid repair at that time.
Oh.
That is very important, because once the patient develops LV dysfunction and the PH happens, RV further dilates, the surgical valve option gets, it's not there at all, because the prognosis, the mortality becomes 25-30%
right.
if they intervene surgically. And in these cases, tricuspid valve interventions come into picture. So if this is a very clearly ACC has given guideline that even in mild to moderate TR, when a surgeon is dealing with left-sided pathology during surgery, and if the patient has RV dilatation, dysfunction, annular dilatation, they should go for.
So concomitantly, they should look at the tricuspid valve, assess the tricuspid valve, and if they understand and evaluate that tricuspid valve is leaking, there is some degree of regurgitation, they should immediately repair that.
Prior, beforehand, how the patient, RV structure is and RV, dilatation, annular size, and the threshold should be lower, and as per the guidelines, they should work rather than waiting and watch, because afterwards, when the problem deteriorates, then the surgical options are less, and there comes the potential.
Sure. So as you said, that tricuspid regurgitation, secondary to left-sided heart disease or primary tricuspid regurgitation or even regurgitation secondary to right ventricular dysfunction or pulmonary artery disease leading to tricuspid regurgitation, something has to be done, because this is an important determinant of outcome, of prognosis, right? So, and we are also talking about the surgical valve or surgical approach to repair or to correct this tricuspid regurgitation. What is the surgical way of doing it? But how the cardiologists, particularly the intervention cardiologists who are doing structural intervention nowadays, are thinking or performing such kind of repair of tricuspid valve regurgitation.
Yeah. So there are situations where surgery is the only option, like someone has infective endocarditis with tricuspid valve and TR. There is no other option, you have to go for surgery. Someone has a kind of a lead of a pacemaker on ICD, which is causing TR, then you don't have other option.
Sure.
Then you have to go to surgical tricuspid valve repair. And even in severe or torrential TR, if the patient has a kind of a normal LV function and PA pressure is not very high, RV is not very hugely dilated, then still you go for a surgical repair of the tricuspid valve. Better to go with annuloplasty, that is ring annuloplasty, and a rigid ring annuloplasty gives you most, fine results, better results.
With the stability of the valve cusps.
Once the LV dysfunction sets in, RV dysfunction sets in, PA pressure goes high, and the RV function of the TAPSI is very less, with volumetric analysis symptoms. These conditions, we can risk evaluate this. We can make there's a we
Scoring
can
system.
scoring system, considering the LV function, RV function, TAPSI, and then PA pressure.
Any role of MRI or imaging technique?
Yeah, so these they quantify better the RV function and the RV volumes and everything, and annular sizes. So once these are going into a high risk for surgical intervention, then the percutaneous intervention come into picture, and we have options like we have 5 options.
Oh, 5 ways.
Yeah.
Oh, sure.
So the first and foremost is clip devices. We had a huge experience of clip devices
Because people are doing mitral clip, mitral regurgitation. We are correcting that by putting a clip across the mitral valve called mitral clip.
Yeah.
So same thing you are talking about?
Yeah. So the edge-to-edge repair is one option. Second is the annuloplasty percutaneous with cardio bands and dry bands, and then the annular size becomes around 8 to 16% lower. It reduces by 8 to 16%, and that's how it reduces the valve leaks. But their residual leaks are very, very, very high in these cases.
Right.
That's why cardioband is not picking up. Besides that, they have got high chance of vascular complications, more of bleeding, and some adjacent structure like coronary arteries get trauma. And
because right coronary artery is next to it, I believe.
3 to 6 millimeter posteriorly. So these are the band devices. Then we have got percutaneous valves.
Tricuspid valve?
Yes. Tricuspid valves, and these are heterotropic and orthotropic devices.
Oh, right. Okay, sure.
Heterotropic means we are not implanting a valve at the tricuspid level. We are implanting a valve, SVC, IVC. So these are just like a trick valve, and so they don't. So these are the only option tricuspid valve replacement devices available in India. We only have a trick valve, heterotropic. We don't have a percutaneous tricuspid valve, replacement device in India. These are like Evoke and Intrepid devices from Medtronic. These are not available in India. They're still under experimental phase.
Sure.
We don't have much robust data. Yeah.
Out of these different ways of doing it, let us say what is called the tri-clip, like mitral clip. Second is cardio band, or like a mitral or tricuspid annular band. Third is valve, as you mentioned, probably the steep valve of the superior vena cava and inferior vena cava level, and there are other 2 or 3 more options.
Devices which can occupy the central part, where there is a balloon type of device,
Agreed. So
foam-filled device, on which the valves oppose, and there's coaptation happens, and that reduces the leak. But still, the results are not good.
So out of these 4 or 5 options of doing tricuspid valve repair by transcatheter manner, which one do you think may be an acceptable one? People are practicing most, and the literature has got maximum evidence to show the superiority of tricuspid valve repair by transcatheter technique.
So as of now, we have a very clear-cut idea that the winner is edge-to-edge repair,
which is tri-clip.
Clips.
Clips.
So the initial experience was with the same mitral clip devices. They were being used in a tricuspid valve as well. But now, as dedicated tri-clip devices has come, and the trial which was there, Illuminate trial, 30-day mortality was 0.
Oh.
So that from there it has given a very, very good insight that this device is really going to work, and it's a very safe device. You go through venous system, and place it and monitor it well. So with increasing experience and refinements in their hardwares, tools, from mitral clip to tri-clip, the complication rate has really drastically come down. It's a very safe device, and results are much better. So all other options are utilized and thought over when these clips are not a suitable candidate.
Right. The other thing is that, like, which group of patient do you think that there is surgically is not the right kind of procedure for those patients? Maybe elderly individual, or gross LV dysfunction, or even right ventricular dysfunction. Although right ventricular function assessment is not as simple as it appears to be, there has to be a volumetric, analysis of right ventricle to find out the actual pumping function of the right ventricle. So, which group of patient will be exclusive for transcatheter tricuspid valve repair?
Yeah. So transcatheter tricuspid valve repair, number one, the patient should be having surgical high surgical risk. So you rightly pointed out LV dysfunction, RV dysfunction, pH pressure, clinic very sick patients, COPD patients, euro score is very high. And provided the tricuspid valve morphology is suitable for triclips.
Oh.
So it should not be too much teethering. The coaptation should not be, the gap should not be more than 11 millimeter where the results are not good. So, and very hugely dilated annulus. So these three factors, preclude the use of, triclip devices.
Correct.
And the risk situations when the surgical risk is very high, not suitable, then H2H repair should be considered.
Right. And then what is the long-term sort of result that we have right now in the literature after triclip or tricuspid valve clip repair?
Yeah, so we don't have much long-term results with triclips, but still 1 year results are there. With in TriLuminate, data is there, and these are really acceptable. The success rate of these procedures with triclip is around 85-90%. And 30-day mortality is around 6 to 7%, so it's very acceptable. Not 30 days, 1 year mortality is around 6 to 7%, and 30-day mortality was 0 as in TriLuminate data it showed. Other devices like cardiobands and tribands and percutaneous valves, they have got a real concern, and still we are waiting for some good positive trials. It's only end up with more than two devices, more than two clips.
Yeah, so unlike mitral clip again, I think many of those mitral regurgitation may require more than one clip.
Yeah.
So when tricuspid valve repair, I think sure that they would require more than at least two clips, maybe more.
Yeah. And we have to start with adjacent to the anteroseptal commission, because there the gap is less. So you start there, you put a clip, then again from medially also in central part you reduce the gap, and then further clips can be
done
given.
again.
So that's how it's done.
Right. You mentioned that there is a coronary artery very close to the tricuspid annulus, about 3 millimeter. What about the atrioventricular node?
Yeah, so these are very close, and with the surgical tricuspid valve replacement, chances of pacemakers are 35-40%. So it's a real concern. AV node, presence of very close coronary arteries, either you go surgically or percutaneously, or you're putting a device, valve there. These are going to cause a very high chance of pacemakers as well as. Yeah.
How much skill is required for the operator, and how much time does it take for an operator to acquire that skill? Of course, with time it improves, but what would be the kind of a learning curve for the operator to do a tricuspid valve transcatheter repair?
Yeah, so the experience is not huge with globally with many centers doing it, very less centers doing it. So it's very difficult to comment at this moment. But obviously, with those operators who are very adept in doing mitral clip devices, there the learning was very short. They can do it. But for those who are
new,
who have no or less experience with mitral clip, tricuspid learning curve will be really difficult.
But again, with time, I'm sure even the hardware also will improve. The delivery sheath and the valve, the clips and other things also will improve, and with time I'm sure this will be a quite acceptable technique. So what is your idea, or what are your thoughts about the future of this transcatheter tricuspid repair for the interventional cardiologist? What would be your take-home message for our audience?
Yeah, so the final summary, the surgical threshold of doing for a repair of tricuspid valves during the surgery of left side should be very less, and it should be, the guidelines should be adopted and adhered to. Number one, it should not be left out. Second, all surgically turned on patients or high surgical risk patients with favorable anatomy for tricuspid valve H2H repair, we should go for TER as the first option. And the rest of the devices, they don't have very clear and good evidence, so that we can jump on these devices. Future looks like these devices will further refine H2H repair devices.
Sure.
So similar, I think fate is waiting for triclips and tricuspid valve H2H repair.
So there is a future of tricuspid valve repair, unlike sort of surgical valve repair. So as you heard from Dr. Dilip Kumar, that structural heart valve intervention is progressively becoming popular, and interventional cardiologists are getting trained and acquiring skill to do valve replacement by catheter with time, and progressively the volume and number is increasing. You heard from him that by this time 120 million patients are already having mitral clip repair. I'm sure clip repair or tricuspid valve repair by tri-clip technique also will progressively increase. But we have to wait to get more data and more information. So obviously, the structural heart valve intervention is progressively increasing worldwide, and even in our hospital, in Medica Hospital, we are probably now the leader of structural valve intervention, because in Eastern India as well as in Bangladesh, we are doing highest number, or we have already done highest number of aortic valve replacement by transcatheter technique, TAVR. I'm sure that mitral clip is also, we have lined up some cases which we will be doing very soon, and maybe by next few months time we will also be trying to do tricuspid valve repair. So I'm sure there are more to come, more to hear, more to learn, and please watch our program Medica Cardio Talk. And if you have any question or any feedback, please do let us know. We'll be very happy to come back to you with answers and suggestion and advice. Thank you very much for your attention. Next time we'll see you on 22nd Medica Cardio Talk.